I would like to talk more about local treatment. You know, in the old days, women were not given an option about what sort of surgery they were going to have. And again, women might have also presented later in the course of their breast cancer, but you would sign a consent and you would wake up having had your breast removed and most of the tissue behind your breast, the pectoralis muscles, and this was a very radical surgery. And over time, some bright light decided, did we need to do mastectomies in all women? And they did a number of studies and found that lumpectomy plus radiation was equivalent to mastectomy in terms of survival benefit. So there is the option of having a lumpectomy and having the lump removed. Now, there's certain cases where that might not be possible. For instance, if a woman is very small-breasted and the tumor is large, then that would not be as possible. Or if the tumor is directly behind the nipple, aesthetically it wouldn't look as pleasing. Women do have the option of trying to shrink that tumor down first with some chemo and possibly followed by radiation. But lumpectomy is usually done if there's a well-localized small tumor. And the other thing too that is new is in the old days, there were lymph nodes removed from under the armpit or the axilla, and it was called an axillary lymph node dissection. And the way I think of it is like a 3-story parking garage. And they would go in and routinely remove lymph nodes from levels 1 and 2. Now we have 600 lymph nodes in the entire body, so they would remove these lymph nodes. It wasn't like they were removing all of the lymph nodes, but they would remove a representative sample. But the problem with this was that removing the lymph nodes in the armpit increased markedly the chance of having a chronic, debilitating condition that we call lymphedema, where the arm on the side of the surgery could become swollen. And this is a lifelong condition. And now it still occurs. It's treatable. It is chronic though, and we try to avoid doing that. So a newer surgery was discovered called a sentinel lymph node biopsy. And that is a procedure where a radioactive tracer dye, which is also blue, is injected in the areola. That's the colored part of the breast around the nipple on the side the breast cancer is found. And this very painful procedure, and I now have a way to make this less painful, is a series of 4 injections at the 12 o'clock, 3 o'clock, 6 o'clock, and 9 o'clock positions, if you can imagine the areola being the face of a clock. So these injections, the whole thing might take 30 to 60 seconds, but it's very painful. In fact, COPE in 2009 did a study polling women who had had this procedure done without any kind of topical freezing. And women rated the pain as being 10 out of 10. That's 1, a little pain. 10, you'd like to blow your brains out. So we now know that there's a wonderful over-the-counter product called EMLA, E-M as in Mary, L-A. This is a topical anesthetic that's widely used now. We use it in electrolysis, tattooing. We use it in infant circumcision. And it costs about $10 for a 5-gram tube that you can apply thickly to the areola 2 hours before your procedure, and just put some cling wrap or saran wrap in place with some tape and remove it just before you have your procedure. And this will markedly decrease the pain. But the great news of this sentinel lymph node biopsy, which is now the standard of care, is that if they find out after your surgery, lumpectomy or mastectomy, it'll take about 2 weeks. If they find out you have no cancer in these lymph nodes, the first draining or sentinel lymph node, then you do not have to have any surgery to the armpit or the axilla, which will again greatly reduce your chance of having any problems with the lymphedema. So that's an overview of local treatment.